Welcome to the Clinical Skills Podcast for Peripheral Venous Cannulation. This podcast will cover the procedure of the insertion of a peripheral venous cannula in an adult patient. Intravenous cannulation is the insertion of a hollow tube into a vein to allow either drainage or installation of substances for a short period of time. We start with an overview of the indications and contraindications of peripheral venous cannulation, assessment of the physical and psychological needs of the patient, choosing the correct equipment, standard precautions, and the anatomy of the cannulation site. The procedure of venous cannulation is illustrated fully, and some of the possible complications are described. Indications for venous cannulation include administration of intravenous drugs, fluid and electrolyte replacement, administration of blood or blood products, blood sampling, and for emergency IV access in patients who are likely to become unwell. Contraindications for venous cannulation include thrombosed veins, inflamed or bruised areas, hard veins, signs of phlebitis, and edematous or scarred areas. It is important to address the individual's physical and psychological needs, which are dependent on and influenced by the patient's condition and circumstance. Assess how appropriate or necessary this invasive procedure is for your patient. Recognise that there are some circumstances when assistance may be required, for example if the patient is confused, has poor venous access, or is very anxious. Various factors can impact on the condition of veins in the patient. These include the age of the patient, previous use of the arm, obesity or malnourishment, edema or dehydration, repeated access for drug therapy, for example warfarin or long-term steroid use, and temperature. A good vein should feel bouncy, feel soft, refill when depressed, be visible, be straight, and be non-pulsatile. The following steps can be taken to improve venous access: the use of a tourniquet to promote venous distension, lowering of the extremity to below the level of the heart, and, if required, apply warm compresses or immerse the limb in a bowl of warm water to increase vasodilatation and promote venous filling. The following precautions should be observed during the procedure. For patients receiving anticoagulant therapy, there will be an increased bleeding time post-procedure. For patients with known blood-borne infections, it is advisable for a competent practitioner to obtain the sample. There are psychological considerations that should be taken into account in some patients. The patient may have had a previous negative experience, in which case reassure them and check for any sites that were difficult to access previously. The patient may have a needle phobia, in which case use methods of distraction to remove the focus from the procedure. In the case of fear, reassure the patient that only 2 attempts will be made before seeking help. Finally, some patients may not be well informed, which can lead to anxiety and fear. This can be alleviated by communicating and informing them what the procedure involves and why it is beneficial to them. Before commencing the procedure, identify yourself to the patient. Check the patient's name, date of birth, and hospital or community health index number and confirm this against their wristband. Clearly explain the procedure to the patient and request consent before continuing. The following equipment is required for venous cannulation: alcohol hand rub solution, gloves, a tourniquet of appropriate size, a 5 ml syringe, cannula and saline flush, gauze swabs, adhesive dressing for fixation of the cannula, a sharp spin, and some alcohol wipes. There are a wide range of cannula types, and it is important to use an appropriate size for the chosen site and patient condition. The ideal cannula should permit optimal flow rates, cause minimum discomfort to the patient, be easy to insert, give high, consistent and reliable performance, and have an integrated port to provide needle-free access. This table lists the different cannulas in use and their clinical application. It is important to thoroughly wash or gel hands following the correct clinical procedure. Put on an apron and wear an appropriate size of gloves. In order to proceed with the procedure safely, it is important to understand the vasculature of the forearm and hand. It is common to find a suitable vein on the dorsal aspect of the hand or the distal forearm. Most veins are suitable, but the preferred veins for venous cannulation are the cephalic vein, the basilic vein, the dorsal venous arch, and the metacarpal veins. It is important to avoid the arteries in the hand, particularly the radial artery, which has a large branch in the anatomical snuff box and could be punctured accidentally when trying to gain access to the cephalic vein. In the event of arterial puncture, there will be a high pressure release of blood from the site. If this occurs, remove the needle immediately and apply direct compression over the puncture site for at least 5 minutes. It is best avoided by checking for pulsation prior to insertion. In the preferred veins described here, most of the nerves are situated clear of the cannulation sites, but care should always be taken when performing the procedure. Now you can begin with the procedure for venous cannulation. Begin by applying a tourniquet to the patient's arm. Inspect and feel for veins at an appropriate site. The basilic vein is used here. Cleanse the area around the vein thoroughly using an antiseptic wipe. Allow 30 seconds for the area to dry. Remove the cannula needle from its packaging. Return to the appropriate site and stabilise the vein. Insert the cannula with the bevel facing upwards at an angle of 30 to 45 degrees and warn the patient to expect a sharp scratch. Be aware of the depth of the vein and be careful not to penetrate into the surrounding tissues. A flashback should be seen when the needle enters the vein. When this occurs, withdraw the needle from the cannula by a few millimetres until a second flashback is seen along the cannula shaft. Gently advance the cannula into the vein in a smooth, continuous motion. If insertion is successful, apply light pressure over the vein above the tip of the cannula whilst carefully withdrawing the needle. Remove the tourniquet from the patient's arm. Remove the needle and dispose of it safely in the sharps bin. Connect an appropriate cap or interlink system to the end of the cannula. Open a fresh, sterile dressing, note the date and time on it, and secure the cannula in position. Ensure the patient feels comfortable with the cannula in situ. The cannula should then be flushed with 2 mm of 0.9% saline. Open a new syringe and draw up the saline solution. Remove any air bubbles from the syringe. Attach the syringe to the cannula and flush with 2 ml of saline. Replace the cannula cap. Gloves and apron should be disposed of as clinical waste. If no flashbacks are seen, or if the cannula will not advance into the vein with little effort, withdraw the cannula and discard of it safely and apply gentle pressure over the puncture site if there is any bleeding. One of the main problems encountered during venous cannulation is difficulty in gaining venous access, particularly in elderly patients, those who have undergone a previous course of chemotherapy or had a prolonged hospital stay. This can be addressed by lowering the limb below the level of the heart to promote venous filling, using other accessible peripheral veins, and requesting help from someone with more experience after 2 unsuccessful attempts.